Okay, welcome back from your break. I'm not sure if you're coming from the gastric lecture or if you're picking this one first. Again, my recommendations were to watch the gastric one and then the intestinal one. They kind of go together, and then the liver one and then the pancreas one. But again, you're probably watching them in some random order, so welcome to the intestines. We are talking about the small intestine and the large intestine. In the gastric lecture, we talked about the esophagus and the stomach. The small intestine's made up of three parts: the duodenum, the jejunum, and then the ileum. And then the large intestine's made up of basically four different kinds of colon. It's all colon. So again, we just call it the colon, the large intestine. The small intestine has specific functions for each piece. The duodenum is where the pancreas and bile get together and work with food, which if you came from the liver and the pancreas lecture, you know very much about those, but if you haven't, you're going to get to. That all happens, that magic happens in the duodenum there, which is right out of the stomach. The jejunum is a long piece of small intestine that absorbs nutrients, and then the ileum is the last piece of the small intestine that dead ends into the colon, and that one also absorbs nutrients, but it also specifically absorbs vitamin B12. And then the large intestine, the whole colon, is involved in making sure that your feces, it does a lot of water balance, and so that's where your feces become firm. Like before it's in the colon, it's all liquid. The feces reabsorb. The colon reabsorbs a lot of our water and makes your feces either hard or soft, depending on your water needs. There's a lot of bacteria in your colon that also continue to digest food, and lots of nutrients, vitamin absorption going on in the colon as well. So just a little tour around the intestines there. How do we see problems in the intestines? Well, we talked in the gastric one about the endoscopy, the scope that goes down your mouth into your stomach, and it can make it into the duodenum. So you could do your endoscopy if you only wanted to look at the duodenum, but if you need the jejunum or the ileum, we just don't have physically enough scope to get all the way through the intestines there. You could do a colonoscopy if you were from the we talk about colonoscopy at the end of this one, which is a scope or a tube that goes up from the bottom end and can go through the entire colon, but again does not have the length to get into the small intestine. So the small intestine is kind of like a non-scopable zone that we physically don't have something long enough to get through there. So the only way we can really look into the small intestine is with an abdominal x-ray, a CT scan, and using contrast, which is radiopaque dye, which of course we all know is renal toxic, but this contrast will allow us to see food moving through the intestines. It helps highlight. So these areas here on the CT scan, these are areas with contrast, and sometimes contrast is attracted to certain areas, but you really need contrast to see, otherwise it looks like a lot of dark gray blobs, whereas when you put contrast into vessels, that makes them highlighted. When you drink contrast, it will make the entire bowel highlighted. So that's what they're using contrast for, is just really to provide contrast. It turns the area that has received contrast white. There's also something called a microcamera, which is a pill-sized camera that you just swallow it, and it basically travels kind of like the magic school bus through the intestine and takes pictures at preset times, and you poop it out, but those pictures are transmitted back to a radiologist to read, so we can see the intestine that way as well. The large intestine, the colonoscopy is our choice exam. That is the scope that will go up from the anus all the way up, and it is long enough to make it into the tip of the ascending colon, so it makes it all the way through to the end of the colon there. There is a video on the colonoscopy too, so that you could watch an actual colonoscopy. So we're going to talk about our disorders of the intestines here. Diverticulosis, and I kind of put these differences here: osis and itis. They both have the same beginning. Diverticulum are these little outpouchings here. So having diverticulum or diverticula are just having the outpouchings of the intestinal wall. Diverticulosis is just having outpouchings or having diverticuli. It itself is it is an abnormal finding. Our intestines are not supposed to have these little outpouchings in them, and it's supposed to be smooth, but increased pressure will actually create these diverticuli. So you can imagine if there's a blockage here and there's a lot of pressure behind that blockage, sometimes poop, there's little bits pop out. So many episodes of constipation, food getting stuck in parts of our intestine, low fiber diet, smoking, which slows motility of the intestines, some genetic functions, basically predispose you to having these diverticuli. So having these diverticuli really doesn't, it's not, having diverticuli isn't a giant problem because this is all smooth muscle here. Let me clear this all out. When you're thinking about the intestines, this is not just a hollow wall. This is a layer of muscle, and this is a layer of muscle. So you can imagine, these are like having tiny itty bitty little hernias. They're not hernias that you can see, but they actually interfere with the muscle movement here. So if you have outpouchings through the muscle here, it interferes with the normal motility of this wall, and it's supposed to be squeezing, but these little guys kind of get in the way, and they are actually damaged pieces of the muscle. So you get a lot of cramping as the intestine tries to move itself in these areas of diverticuli. So cramping, abdominal pain, and it's certainly worse when you have increased motility right after eating. So usually patients just have kind of some chronic abdominal pain after eating. There are no outward signs of having diverticuli themselves. The worsening part of having these things is you can imagine that as food and partially digested junk and feces move through your intestines, this can get easily infected. All you need is one little piece of food or something to get trapped in there, and then the bacteria in our gut will go in there and start feeding on it, very easily infected. So if you're having diverticuli, you're constantly on the watch for them getting infection. You can see it's very easy for things to drop into those little outpouchings and get infected. So having this normal kind of gnawing, cramping pain after eating is just a function of the actual intestine muscle wall being a little damaged. We want to give them fiber to prevent constipation, because basically if you have a backup or you have a food, go back. I was going to scribble. Let's say you have something lodged right here, or you have food that's not moving well and can just kind of hang out there. There's much more risk of little pieces of it dropping off into those holes. Whereas if you are constantly moving food past there and bulking up your food so pieces don't fall off and keeping things flushed, the management of having diverticuli is to prevent any further constipation or increased pressure in the bowel. Hopefully those little diverticuli will take care of themselves and pop back into place as the intestine heals. But if they keep getting infected or keep having food in them, they will continue to stay outpouchings. So the goal of treatment for these patients is high fiber, high fluids to keep things flushed and flowing. We don't want anything getting stuck or stopped, because it can fall off the bowel party there and into these holes. So we want stuff flowing through right past those holes and flushing things out behind them. If you stay very hydrated, you're constantly pushing water through those and keeping those diverticuli cleaned out. So fiber and fluids are great. If you are having the cramping, they can do things to reduce the amount of cramping. But again, these are antispasmodics, anticholinergics. They are going to slow down the motility of the intestines, which will actually cause you to have an increased risk of constipation. So if you are slowing down the motility to treat spasms and cramps, then you want to make sure you are fully flushing very well through so that the slower intestine doesn't get constipated up. So high fibers, high fluids, and you can treat the pain with antispasmodics, anticholinergics, because that's what's causing the pain, is this intestinal motility after eating. But remember, taking antispasmodics and anticholinergics slow down motility and increase your risk of constipation. So keeping the fiber and fluids in there to keep things moving is very important. Oh, Lord have mercy, I copied the wrong name. We are going to talk about diverticulitis. Bear with me for a second. This will be ingrained in your mind. This slide goes with diverticulitis. I'm going to just fix this slide real quick. Okay, I fixed both of these slides, but they won't be fixed in your slide bank just yet. So please make sure you make that change on the slide with these little pink intestines here. We are talking about diverticulitis. That's the problem with copy paste. This is itis, which is an infection. So now we're talking about these diverticulosis pouches becoming inflamed or infected, which happens pretty frequently because, like you said, it's very easy for a little piece of food to get into one of these areas, and then the bacteria that live in our intestines just eat up. The cues of this is now you're not just having abdominal cramping, but you are having now a fever, diarrhea, and abdominal cramping, and the pain hurts all the time, not just after eating, and that's because you have an inflamed piece of intestine. So fever, cramping, pain, some of it comes and goes. The level may get worse after eating, but it will always be some kind of pain in that area because it's infected and abscessing. You will also have diarrhea because the body's trying to clean itself out, producing more mucus in that intestinal area, so you might have diarrhea with it. The problem isn't so much having the infection. We can treat that pretty easily. The problem is when these infected areas have their complications. So these diverticuli can abscess and swell to the point that they rupture, which will then rupture into our abdominal cavity because the intestines are on the abdominal cavity. So now we have basically intestinal contents leaking into the abdominal cavity. So if you end up with a peritonitis, again, the same signs of peritonitis, high fever, abdominal pain now, not just in one quadrant where the diverticuli are, but in all four quadrants because you have an infection of your peritoneum. Firm, rigid abdominal distension where it's not soft and bloated, it's actually firm and hard and the patient doesn't want you to touch it. That's a sign of infection in your abdominal space. You could get bowel obstructions where these diverticuli are actually protruding and the abscess gets so big that it can block off your intestine. So if I'm going to draw on this guy here, let's just say this thing grew so big and abscessed, and you have white blood cells in here trying to fix this thing. This thing grows into a giant abscess. It can actually block off some of your intestine. And we will talk about bowel obstruction in a little bit. These are very small, just basically the two main signs of a bowel obstruction are abdominal distension. And when you're listening to your bowel sounds, the bowel sounds are hyperactive above the obstruction because it's trying to push stuff past it, and normal or hypoactive below the obstruction. These could also bleed. These diverticuli can, the abscess can erode into the blood vessels in the intestinal wall. Again, signs of intestinal bleeding. Usually in the small intestine or the large intestine, the blood doesn't have a chance to get up into the stomach. The blood travels south. So usually you only see black tarry stools or bright red blood, depending on how long the blood's been in the intestine. But usually in a small intestine or large intestine, you won't see the blood from the intestines make it up through the surface and have vomiting. Usually vomiting blood comes from upper GI bleeds. An intestinal bleed is going to be a lower GI bleed, and that comes with blood in the stool. And then fistulas are where these infected, these little diverticuli actually create a road, a channel between it and the other organ. And you can see the fistula that's in this picture here is a fistula between the colon and the bladder. So here we've actually putting intestinal contents into the bladder, so that will cause UTI. There are lots of other organs around the area. You can have fistulas to the kidney, you can have fistulas to other parts of the bowel. So any of those things are what we do not want to see out of a infection to our bowel. So if these diverticuli get infected, we will give them antibiotics. That's the number one for any infection, antibiotics. They will get a clear liquid diet. Remember, we wanted them fiber and flushing. We still want them flushing. We just don't want any more food. There's already an infection in there. So we are going to keep that area as clean and pristine and flush it as much as possible. So antibiotics and a clear liquid diet. If they have any worsening cues, so they have any signs of bowel obstruction, bleeding, fistulas, peritoneal infection, or if the infection is not responding to antibiotics or clear liquid diet, their symptoms are not going away, they can bring them in and get IV antibiotics and IV fluids, again, to get rid of that infection. And then they'll probably be NPO for a while on IV antibiotics or IV fluids. If there are any complications like a bowel obstruction or a rupture or fistulas, they will go in and do surgery and clean out that abdomen for any peritonitis. And especially if antibiotics, the IV antibiotics are not keeping it under control, they will go for bowel surgery. And if this creates a great deal of infection or to the point where you need surgery or they have to remove a piece of the bowel, there could be some tube feeding or TPN or PPN needed if there are extensive complications. So again, keeping these from getting infected would definitely be the key. Fluid and fiber intake prevent infection. Will treat the cramping and pain, but remember, an infection gets antibiotics, but antibiotics and a clear liquid diet. So fiber and fluid when they are not infected. So this is prevention. Prevention is fluid and fiber. Treatment, so prevention of itis, prevention of infection, fluids and fiber. If you already have the infection, antibiotics and a clear liquid diet. The only thing we want in that bowel is stuff that will flush. We're not even going to give you food. You already got an infection. So antibiotics and a clear liquid diet until the infection clears up. And then if we can't get that to clear up with oral antibiotics and a clear liquid diet, IV antibiotics, IV fluids, and an NPO. Hopefully that makes some sense there. All right, so that was diverticulosis. Remember, prevent it getting infection, fiber and fluids. If it does get infection, once there is infection, we're going to do clear liquids and antibiotics, with a backup being IV antibiotics and NPO if we need to. We're going to leave our little diverticuli behind and talk about some autoimmune disorders of the bowel. These are a little bit more concerning. Again, diverticuli are concerning, and we don't want them rupturing or anything like that. But these are actually autoimmune diseases, so these are going to be lifelong problems. One of them is celiac disease, and I've grouped that on its own because its inflammation trigger is specific to gluten. It does cause abdominal swelling and abdominal damage. It damages the cilia of the villi. Sorry, not really the cilia. The cilia are things that move it, like little tails. It's actually doesn't damage cilia, villi. I have a picture of that in a minute. And then we have Crohn's disease and ulcerative colitis. Those inflammation triggers are more unknown. Stress, things that trigger most autoimmune diseases, stress, illness. Oh, I didn't finish up that slide. I think I have the causes in the treat and communicate section, but really a little bit more unknown. It's not like celiac disease where we know it's gluten. There's a very quick test for it that will tell you that you have celiac disease, and then you treat it very specifically. Crohn's and ulcerative colitis are constantly having flaring ups and damage happening throughout a lifetime, and both of these diseases cause change in the intestinal lining or the intestinal wall, and are associated with an increased risk of colorectal cancers because of the changes in the bowel wall. And then depending on how much of the intestine is infected, there's issues there. So we're going to talk about celiac disease first, and then we're going to kind of talk about Crohn's disease and ulcerative colitis as a little group because their treatments are the same. So let's talk about celiac real quick. Celiac disease usually is diagnosed in childhood because this becomes pretty apparent. This is an actual allergy to gluten, which is the substance that binds together the carbs in wheat, barley, and rye. And it actually causes a damage to the intestinal villi. So the villi, not cilia, sorry, but villi. The intestinal villi are these little things that stick up and they move food along. They actually cause, when the muscle underneath it, this is the muscle, lining here, and then we have all these little villi sticking up all through here. So as the muscle propels them, they propel food along, but they also absorb nutrients. So in celiac disease, these nutrients, you can see they're just kind of bouncing off. There's nothing to absorb them, so the nutrients just get kicked back into the stool. They never get absorbed, and also your motility is damaged as well, because that's the job of these little villi, is to basically move things along and absorb things as they move along. So these damaged villi, the motility is disturbed, so you have mix of diarrhea, constipation, and again, the intestinal wall will try to move things along, and whenever things are not moving along, it will contract more to try and move things along. So you can have alternating diarrhea, constipation with these damaged villi, weight loss because you're malnourished, bloated abdomen because gases aren't moving around, increased flatulence. Again, things are not being moved and absorbed the way they are supposed to. Usually in children, it's diagnosed early, or it's diagnosed with screening. But if they are not diagnosed, it causes slow growth, malnutrition, rashes, joint inflammation, and it is an autoimmune disease. And if it's never treated, severe malnutrition, failure to thrive, you're not absorbing calcium, brittle bones, yellow teeth, anemias. You're just not absorbing the things that you need to produce all your bodily functions. So it has a very easy blood test. There are gluten antibodies in your bloodstream. So if you suspect celiac disease, there's a very easy test that they can do to rule you in or rule you out for celiac disease. Always checking bowel sounds, bowel movements, and weight. And the treatment for it, the only treatment for it, there are no medications. The only treatment for it is avoid your allergen, which is gluten. So this is a required gluten-free diet because you will end up becoming severely malnourished if you do eat gluten, because it will continue to eat up your villi. Hopefully they will grow back when you stop eating gluten. It stops attacking the villi, and the villi grow back. So they will be avoiding gluten products for the rest of their lifetime. This is a medical necessity, not a diet of choice. Again, they have an allergy to gluten that eats up their villi. And that is found on a gluten antibody test, which I do believe can be done pretty easily at most allergists. While you are having a flare-up of celiac disease, so maybe you ate something, if you're returning of symptoms, means that you've consumed some of the allergen, the villi got damaged, and so after a flare-up and while the intestine heals, you avoid milk, cheese, and dairy foods because those do inhibit healing. But otherwise, celiac, what you need to remember about celiac is gluten-free diet, and need to stay on the gluten-free diet because symptoms will return if you do eat some gluten and you do damage your intestine. But no lifelong, and the intestine should heal as long as you stay away from gluten. Here, Crohn's disease and ulcerative colitis, we have kind of a bigger problem here. This inflammation ends up damaging the entire bowel wall. There's no specific thing that causes it. It's an autoimmune, meaning the white blood cells attack your own intestinal wall. It's not in response to an allergen. And nobody really knows what causes it to do. They think it might be rooted in some gut bacteria, but they have not done, they're still doing plenty of research on these inflammatory bowel diseases. But what you're going to see is because this entire bowel wall is getting damaged with a flare-up or with this autoimmune response, it's basically eating through the intestines there. It's causing inflammation of the intestine. I always like to tell people when we talk about inflammation, think about cutting, our hangnail. Think about, ripping a huge hangnail on your thumb. What happens to that area? It swells. That is a normal response, and that is a white blood cells getting there, they're cleaning things up, they're doing repair processes, and that is a normal process, and the swelling goes away once everything is healed up. But here we are having this swelling and this inflammation all the time, coming and going, but constantly all the time, and that ends up damaging the wall and creating changes in this wall, a lot of scar tissue along the way. So while you're having a flare-up and your immune system is kind of attacking your your intestinal wall here, you could be bleeding. So that would be intermittent bloody diarrhea. So depending on where in the intestine is, if it's in the small intestine, it'll be darker red stool. If it's in the colon, it could be, brighter red blood. But usually this is in the intestine, so this blood gets digested before it's eliminated in the stool. So it comes out in the stool as dark red or tarry. Constipation is due, so people are like, well, which one is it? Well, it's both. Because the bowel wall is being broken down and is bleeding, you will have that blood eliminated as diarrhea, but you're also having swelling. So there's swelling and erosion, and the swelling causes thickened walls, damaged muscles, and can cause blockages and constipation. You have cramps and pain because, again, this is motility. This is all muscle here. So this muscle is now swelling and damaged, and so you get cramping as this is trying to move things through. It's trying to propel. This muscle is trying to propel, and it reaches this spot here that is just not propelling well. So this area ends up propelling harder, trying to push things through, and you end up with cramps and pain. A low-grade fever, because this is a autoimmune process, there is not an infection, but an inflammation. An inflammation gives you a low-grade fever, so less than 100. Loss of appetite, weight loss, fatigue. Again, this piece of your intestine here is supposed to be doing a lot of absorbing, and it's not being absorbed. So you actually lose some nutrients, weight loss, fatigue, an autoimmune constant response does wear you out. And what this is a very specific finding. If they did a colonoscopy or a CT scan, they see the thickening of the cell wall, and there's a cobblestone-like appearance to it. So they will see the thickened intestinal wall and the cobblestones basically give you the diagnosis of Crohn's disease. There's no specific antibody to look for, so they go off of pain, symptoms, and CT findings. The worsening problems of this is, again, we are having problems with our wall. We're constantly attacking the wall. You can get obstructions from that swelling. You can get infections from abscesses that are growing there, and you can have bleeding and anemia and hypotension depending on how much is bleeding. You can have just a small little venous ooze, or you could have a large arterial bleed depending on what's going on and what has eroded in your intestinal wall there. But eventually this will turn to scar tissue because it keeps getting, this one area keeps getting inflamed. And with Crohn's disease, you can have multiple areas of the intestines. I do believe I have a better slide about the difference between the two. But ulcerative colitis, and I love that colitis goes with colon. Crohn's disease can be in any intestine, but ulcerative colitis is only in the colon. And it only damages the upper surface of the of the wall, calling ulceration. So you get ulceration, so almost like peptic ulcer disease, ulcers the stomach. This is ulcers of the colon, but a great deal of ulceration going on. So you can see from our picture here that we have a lot of bleeding kind of and oozing, cascading around down the colon. And then, of course, you're also passing feces through there. So you certainly get a lot of infection as well through there. There's a lot of bacteria, there's a lot of bleeding, this bloody diarrhea, no constipation with this because everything's slipping right through this channel because it is constantly bleeding. And this is brighter red blood because it's the end of the intestinal tract in the colon. So this is much brighter blood than the Crohn's disease, which usually attacks the smaller intestines and is darker bleeding. No constipation with this because, again, we've got like a water slide going on here, except it's a blood slide. Low-grade fever because it is an autoimmune response. So instead of causing swelling, it is causing ulceration. It's causing breakdown and erosion rather than the swelling and inflammation that happens with Crohn's disease. And they'll see these ulcerations and abscesses. And usually because this happens in the colon, we do a colonoscopy and they find it. It looks just like this on the finding. The worsening symptoms of this, of course, because this is ulcerations, there's a lot more bleeding. So I put bleeding higher up on the list. You can see on my last one, I kind of did order these in the frequency. So with Crohn's disease, we end up with more bowel obstructions and infections than we do bleeding. And in ulcerative colitis, we end up with more bleeding and infections than we do peritonitis, which is where the ulcers erode through the entire wall. But again, both of them cause damage to the actual intestinal wall. Celiac disease only damaged the villi. And here we're actually damaging the muscle wall of the intestine, increasing your risk for cancer. So what are we going to do for these boys? We're going to monitor them, and this is my picture here that I like of Crohn's disease. You can see Crohn's disease can affect multiple pieces of intestine at once. Again, we're not really sure what the trigger is here. We think it's the bacteria, the gut bacteria that reside in that certain area, but it can affect small and large bowel or small or large. There's no rhyme or reason to where in the intestine that it attacks. Here, ulcerative colitis will only attack the colon, and it's usually the latter part of the colon. There's some pictures to kind of show you the difference in the two different diseases here. Again, if you think of Crohn's disease, this is an entire thickening. This whole area ends up becoming almost vasoconstricted and too thick to wrap around. It has that cobblestone appearance. And ulcerative colitis, the area is eroded away and much, much thinner and always bleeding. So the pain level and location will help us kind of determine what quadrant, what areas are being troublesome. Bowel sounds are very important here because, again, if we're having constipation or areas of constipation, then what you're going to hear, if these areas have constipation, you will hear more hyperactive bowel sounds above the occlusion and less hyperactive around. So you listen to all the quadrants, hear what you're hearing in there, and see if it goes along with what you're seeing coming out the other end. The stool is the big telltale sign. The frequency, is it diarrhea? Is there no stool? The consistency of it, is it bloody? Is it mucoid? What is coming out of your back end tells us a lot about what's going on in the processing center there. So we're definitely going to be looking at our stool and what is coming out to help us diagnose what's going on in our body there. Temperature is for any kind of infection. We expect them to have that low-grade temperature, but we don't expect them to have an infection, which would be a higher-grade temperature. Blood pressure and heart rate would be for any bleeding, to make sure that the bleeding is not getting worse to affect our fluid volume status. And weight will also help us with telling whether there's nourishment or malnourishment going on. The treatment for both of these, Crohn's disease and ulcerative colitis, is to give an anti-inflammatory medication named aminosalicylates. I think I said that right, aminosalicylates. They are specific to decrease GI inflammation. So it's not like taking a non-steroidal or a steroid that will decrease your inflammation throughout your body. These specifically decrease inflammation in the GI tract, which is exactly what you want it to do. So mesalamine and sulfasalazine, of course, if you have sulfa allergies, you would be taking mesalamine. But they are both aminosalicitates, and they are specific for GI inflammation. So aminosalicitates are your main treatment for Crohn's and ulcerative colitis. We're not giving them for celiac disease, because the treatment for celiac disease is to stop taking the thing that is causing your villi to die. These, we don't really know the causes. It's autoimmune, meaning we have no clue. So we're just going to decrease inflammation. You can use steroids. I will talk to you later in the adrenal gland lecture about why we're not a big fan of steroids. Steroids have a lot of side effects with them. They do suppress the immune system and decrease inflammation, and they can be used with your aminosalicitates during severe flare-ups, but we do not use them on a daily basis. Once those meds stop working and you're continuing to have problems, they can suppress your whole body immune system response. But again, there's a risk benefit there. When we are suppressing our whole body immune system, you're at much high risk of other kinds of infections. These are anti-rejection medicines. These are what you'll use after organ transplants. And again, they come with a high risk of, other kinds of infections in your body. So there's kind of a period when your aminosalicitates stop working, and you are having either so much bleeding that you're having anemia from your colitis, or you are having frequent obstructions and flare-ups and complications from your Crohn's, that surgery becomes the option. And they're usually given the choice: do you want to continue with anti-rejection meds and not do surgery, or do you want to do surgery? And they will remove the troublesome diseased piece of the bowel. Hopefully, if the piece of the bowel that is involved is not too large, they can anastomose, meaning bring the other ends of the intestine together. And if you can bring the other two intestines together and sew them together, then they will function as a normal intestine. So you can see here we've done a surgery. We've done a surgery to remove this piece of the colon, and then they bring that down and create a short colon, but it's still a colon. If they cannot bring those ends together, maybe they're too far apart, maybe they're too damaged, if they cannot bring those ends together, or sometimes in the meantime they let the swelling go down before they try to bring things together, is that they will take this end and turn it to an ostomy. And this end just becomes non-functional, because then everything will be draining out from here. And I think you can see that in the slide below. Here they've removed this large piece. They decided not to put the two ends together, and so the end will just be diverted out to the outside and become an ostomy. Surgery, really, you can see 60 to 70% of people with Crohn's disease end up with bowel surgery. 25 to 30% end up, after ulcerative colitis, will have some kind of surgery. And really, the surgery is done when the medications no longer control your symptoms, or if you are having too many complications, obstructions, fistulas, fissures. If you're having too many of those, they'll need to just go in and resume all that, or remove that piece of the intestine that is bad, and hopefully that will solve a lot of your problems. But it is a last chance resort, and a lot of patients, if there is an entire amount of intestine that is damaged, might come out with an ostomy. Some surgeons will wait for the swelling to decrease on either end and then go back in later and try to reconnect them. So they might have a temporary ostomy, or they might have a lifetime ostomy, depending on the condition of their intestine there. So these inflammatory bowel disease, Crohn's and ulcerative colitis, do cause a lot of complications. Crohn's disease does cause a lot of obstructions, bleeding, fistulas, fissures, abscesses, a lot of other infections, possible peritonitis, and ulcerative colitis causes mostly anemia and infections as well. But when the side effects and the complications become more than being able to control the disease, then bowel surgery is involved. So diet modifications can help. Again, they're constantly doing research on what foods can be triggers. It's kind of like migraines. You have to find your trigger. So soft, bland foods, limit dairy products, adequate fiber, eat smaller meals. These are more for comfort. The possible triggers, again, missed medications. If you're on immunosolicitates and you stop taking them, then you will have flare-ups. Smoking irritates the intestinal motility. Caffeine irritates intestinal motility. Some hormones, illnesses, infections, things that stress the body out. Could be possible triggers. Again, we don't know a whole lot about it. Always a good idea, though, to, if you're having any kind of bleeding or blockages, remaining adequately hydrated. Again, we need to stay hydrated if you are having any kind of bleeding from your stools. If it's a small amount, but you need to replace that volume. If you are at risk for constipation, you need to keep your stool and your fluids flushed so that you can keep things moving through those large swollen parts of your intestine. There's support available on the Crohn's Colitis Foundation page, which might actually be interesting for you to go and take a look at. And for these immunosolicitates, the inflammatory medications specific for GI disease, Crohn's and ulcerative colitis, they can cause stomach upset, but they're meant to decrease inflammation, so they're decreasing inflammation in the stomach as well, and that can cause stomach pain and decreased so just like with any other the non-steroidals, it can cause problems with our stomach, headaches, and just in case a patient has digoxin, it does interact with digoxin. And I think a just dosage with liver impairment should go with every single med that exists. And that is our inflammatory bowel diseases. So I will go quickly, I'm only 41 minutes into this one, into intestinal disorder. This is irritable bowel syndrome. Irritable bowel is just that. It is not an inflammatory autoimmune disease like Crohn's and ulcerative. It's not an allergy to gluten. It's not autoimmune inflammatory. Nothing in the bowel is dying or being damaged. This is basically a problem with innervation to the bowel. And they call this brain-gut nerve dysregulation because basically the brain is in charge of sending out those parasympathetic, sympathetic systems. But for some reason, things are running amok and the signals going to the bowels are not appropriate for what is happening there. So these are linked to a little bit more of the mental disorders, anxiety, depression, migraines, stress. Hormones might have a play in it. They're not really sure. They're still doing a lot of research. But the nitty-gritty is that sometimes the bowel moves fast, increase motility. Sometimes the bowel moves slow, decrease motility, and not always when it should. So normally the parasympathetic system will increase the motility of the bowel because you're supposed to be digesting, but maybe those signals never get there and the bowel doesn't increase its motility while it's got food in it, and things kind of get stopped up. Or maybe when it's empty and it's not supposed to be moving, signals are getting sent to it that it needs to be contracting and moving things along when there's nothing in there. So alternating cramps and diarrhea, alternating with bloating, gas buildup, and constipation. And you can't tell which one's which, and the bowels don't really respond well to its signals the way it should. And so you have alternating constipation and diarrhea. But there are no changes to the bowel wall. It's just a innervation contraction issue. There are no worsening cues with it. Those are bad enough to have constant cramps, diarrhea, alternating with bloating and constipation. and your food just doesn't process the way it should. Assessment is really the bowel sounds and the pain, the stool, just to say whether you're in a constipative episode or a diarrhea episode. Because it's related to brain innervation, reducing stress and anxiety, using probiotics is possibly helpful. Decreasing foods that create gas, because when your body is in a low level intestinal motility, a lot of gases build up, so you don't want to add in foods that are going to increase this problem. And this is the diet that goes with the FODMAP foods, which are basically raw fruits and vegetables and grains and carbonated drinks and beans and things like that. So you want to reduce your fermentable foods or things that create a lot of gas. Because when you're in a slow motility, and you have no control over this, your intestines are either slow or crazy motility. But when you are in these constipation, slow motility, you have a lot of gas and bloating already. You don't want to add to the problem. And really, it's symptomatic treatment. If you're having constipation, laxatives and fiber. If you're having diarrhea, antidiarrheals. Maintaining adequate hydration is always important. You can do heat, relaxation, antispasmodics. But again, for pain and cramping, if you're taking antispasmodics, anticholinergics, you will just flip yourself over into the low motility. And you might already be having problems with flipping into low motility. So really, unfortunately, for irritable bowel syndrome, there are not a lot of good treatments. We're just trying to symptom treat, really. They're not very well aware yet of the causes of irritable bowel syndrome. Appendicitis, I think probably most of you are pretty aware of appendicitis, but just in case you don't remember appendicitis, the appendix is this little vestigial, useless, basically piece of tissue. It's a old tissue that doesn't have any purpose that we know of. There's theories, but it is at the very beginning of the large intestine. So the very end of the small intestine, beginning of the large intestine, and it sits in the right lower quadrant. So when this thing gets inflamed, usually by some piece of food or something blocking it up, it will inflame and swell and create quite a bit of pain in the right lower quadrant. It's known as McBurney's point, and it's really just right above the pelvic bone on the right side of your, I know half of you are probably feeling for it right now. So right above the pelvic, in between the pelvic bone and the umbilicus, if you press down there, if you have appendicitis, it creates a great deal of pain. There's also pain and cramping that radiate around to the groin or the back. Low-grade fever because it's inflammation, increased white blood cells because it's inflammation, some nausea, vomiting because there's inflammation in the GI tract, and diarrhea because, again, when there's inflammation in the GI tract, there's increased motility, and you can have diarrhea with that. The damage with this, the treatment is to go in and remove this inflamed appendix because we don't need it. The problem could be that if your appendix perforates, meaning that it explodes basically, and then you have an infection in your abdominal cavity and leakage of tissue. So I will definitely not tell you my story of appendicitis, which I did have after working a night shift and had 2 babies at home, and thought I had food poisoning because we always ate at night at some crappy place that we probably shouldn't be eating at, and we didn't want to go visit because we thought it had roaches. And anyway, so we ate there, and I come home the next morning, I start having abdominal cramps, nausea, and I said, oh my gosh, I got food poisoning from the food I ate last night. And went on throughout the day, and of course, like a good nurse, I didn't think appendicitis because I didn't want to have surgery. So I ignored it and said, it must be food poisoning, it'll pass in 24 hours. Ignored it to the point where I remember putting a basket down on the stairwell. I was carrying up some laundry, and I had to put it down and breathe through the contractions because it felt like labor contractions. Those were those wave-like abdominal cramps. And only later on that night did I go and do McBurney's point, and I'm like, Yeah, I got appendicitis. So by the time I got my kids, of course, because we're nurses and we're moms and whatever, and I'm an idiot. Basically, bottom line. I woke up the next morning after knowing that I have appendicitis, got my kids all to get someone to come over, take care of my kids, took care of my kids, got them breakfast, went to the ER, and in the ER, the pain went away. And I said, oh my gosh, pain went away. Stupid. See, I knew I had nothing wrong with me after all. Turns out the pain went away when the whole appendix bursts. Before your symptoms of peritonitis show up, you have a relief because your appendix burst. So my appendix burst, and I ended up having, I think, 6 centimeters of bowel removed along with it. While they went, and instead of having a nice laparoscopic surgery, I had an open abdominal surgery, and I didn't tell a single soul at that hospital that I was a nurse because I was so embarrassed. Because who in the heck misses appendicitis? This girl, and mostly because I didn't have time to deal with surgery, so surgery dealt with me instead. So don't not listen to your body. But anyway, right lower quadrant pain, wave-like abdominal cramps, and the treatment is to get surgery, antibiotics for the inflammation, NPO until surgery, and then you'll care of the patient after intestinal surgery. For me, I ended up buying myself more time in the hospital with IV antibiotics because I did advance myself to early peritonitis because I'm a fool. So you can always remember that story and don't do as I do. We'll talk about bowel obstruction. Most bowel obstructions are mechanical obstructions of some kind, including constipation. Constipation is a mechanical obstruction, any physical blockage of normal intestinal motility. Crohn's disease does turn into a mechanical obstruction because of the swelling in the scar tissue. So you can see all the different kinds. I'm not going to make you diagnose or know all the kinds, but just anything that causes a blockage to normal intestinal flow is going to cause a mechanical obstruction. There's treatment based on whether, on the causes, but let's talk about the cues of it. All of them have the same cues because there's a mechanical obstruction. And I love this drawing for telling you what's happening around this obstruction. So the obstruction, whether it's a giant bowling ball in your intestine or whether it's Crohn's disease, whether it's a piece of stool, whatever it is, whether it's intestine flipped on itself, there's an obstruction. So below this obstruction, so what is happening here is this is working real hard. Strong cramps trying to push out this obstruction. So strong cramps. So abdominal cramps is big and pain because this is hyperactive here, trying to push this obstruction out of the way. So all in this area, you're hearing hyperactive bowel sounds. Underneath it, this is just running normally. There's not a lot to do, so your bowel sounds should be normal below it. Because there's nothing to do. Nothing's getting past it. Above it, a lot of activity, but the intestines below that don't know anything. All it knows is that stuff is occasionally getting past it around the spasm, and it'll deal with whatever. But a lot of mucus and stuff from all this extra activity going on here, what leaks around it is usually liquid or something mucoid. So people can say, oh, if you have constipation, you don't have any output. That's not true. You could actually have diarrhea and still have massive constipation north of it. Because what's spasming around here, what can make its way around the obstruction, is only liquid. So what's coming out that way is only gas and liquid can make it around the obstruction. So what comes out your rear end is gas and liquid. So just because you're having diarrhea does not mean you do not have an obstruction further north. So let me clear all of this out. So that's what's giving you abdominal cramps and pain is the hyperactivity in this area. You're having spasm around there. You do have a couple of things making it through, but like I said, it's liquid and gas making it around the obstruction. The bowel sounds are going to be hyper above the obstruction and normal, maybe hypo below it. There's really not a lot going on down there to move, so there's no need for it to speed up down there below the obstruction. The abdominal distension is coming from this intestine swelling behind the obstruction. Okay, there's food coming in, still coming down the pike that we have to deal with. Any gas fermentation that's happening is now stuck there. Fluids, electrolytes are kind of, everything's just stuck. It's like a big, car accident that everyone's stuck behind. But what it's doing is, and because everything's hypoactive, is that everything's trying to move behind it. It becomes like a little churning, a churning facility there, and it starts to swell. All this backup starts to swell. Well, when this gets to be high pressure in here, so let's get all this. This is just to be high pressure because of all of the backed up food, fluids, electrolytes, everything's in there. It's high pressure. Things start osmosing out into the abdominal space. So this is the abdominal space. So what we end up doing is we start leaking out fluid, electrolytes, and bacteria across this intestinal wall. So in the meantime, though, that bowel is swelling and will create abdominal distension. When that distension gets so big that this intestine is just under too much high pressure, then it starts shoving stuff out of it. Kind of like a blood vessel, but it's a lot more compliant than a blood vessel. It's got a lot of room to grow, and it will grow. And this swelling can happen not just in this one space. This swelling will happen all the way up. So if this is a small bowel, this could swell all the way back through the entire small bowel, all the way up into the stomach. So it will, there's a lot of backflow area for it to swell. And so it's going to take quite a while before it gets into high pressure there. But eventually it will reach a pressure where it pushes stuff against the wall. So we're going to see abdominal extensions. You're going to see cramps and pain. You're going to have your hyperactive bowel sounds above the obstruction and normal below. You may have mucoid or liquid diarrhea. And of course, anorexia, nausea, and vomiting, because your bowels are getting distended. They're sending a signal to the brain, hey, we're kind of full down here. You don't need to eat anymore. The worsening condition is where our bowel is under such high pressure that it starts displacing, we start displacing bacteria, fluid, and electrolytes across the membrane into the abdominal space. So when it starts displacing, we're in our worsening condition of a bowel obstruction. While the bowel is extending and expanding, we're having all of these cues. Could take days, could take hours, depending on where it is. The higher up in the intestine, the faster you see the symptoms. So if you have, let's draw our little stomach here, and we have all of our small intestines, and then we're going to make our large intestines down here, and then we have the exit out. So basically, we stretch this out. This is a long thing. If we have an obstruction down here in the colon, it has a lot of room before it backs up and reaches that high pressure. It can backflow quite a bit, and that pressure we have a lot of room to grow, basically. Higher up in the intestine, if you have a blockage up here, there's not much room to expand before you start having vomiting and reflux and regurgitation up through the stomach and the esophagus. So the symptoms move faster the higher up in the intestine you go. Does that make sense? So hopefully it makes sense. If not, send me a message or something. So the lower the blockage, like I said, if it's in the lower part of the small intestine or the colon, there's a lot of room for expansion before we start to see any kind of vomiting or trouble. But there's also a lot of room for a lot of distension because there's a lot of bowel there that is getting distended. The higher up, the quicker you see worsening cues, basically. So we're going to keep an eye on the bowel sounds because that's really going to tell us where we are having our problems. So you're basically listening for where is it hyperactive, because we know it's hyperactive somewhere in there. We're listening for where it is hyperactive. We're going to be measuring abdominal girth. That's telling us whether our distension is getting worse. Pain location, quality, of course. Which quadrant is it hurting in? That can tell you probably where to start listening for bowel sounds. For those of you who listen, if you have abdominal distension, you are automatically listening in all 4 quadrants for the full time. Just because you hear normal sounds doesn't mean you can move on. You're listening for that obstruction. If you have signs of obstruction, there's hyperactive bowel sounds somewhere in there, and that will point you to where the obstruction is. Stool frequency and quality, again, if you haven't had a bowel movement in 5 days, probably you've got some kind of constipation obstruction going on. And just because you're having diarrhea does not mean you are not constipated. If you put in an NG tube, which is one of the treatments, make sure that you're checking the suction level and the quantity of the drainage. Temperature for any kind of infection or migration of bacteria into the peritoneal space, white blood cells. And then, of course, they're going to be diagnosing this with abdominal x-rays, CT scans, ultrasounds. We're going to take a closer look at the bowels. Your bowel sound assessment is a big clue as to what area to look for, but they will be taking a look at the whole intestines on our diagnostic test. If constipation is the cause, then let's not put any more food into the system and enemas and laxatives until stuff starts to move. IV fluids to replace anything that's getting out into the abdominal space. We have a lot of, and when the intestines are obstructed, if the intestines are obstructed, then we lose a lot of fluid above that obstruction. And so we usually give fluid replacement. Also, fluid will help things move through the intestines. The more hydrated are, the better we are at keeping things going through our intestines. So you can always tell when you're dehydrated because your stool comes out hard and dehydrated, basically, because we've reabsorbed all our water. The more hydrated we stay, the better stuff flows through our bowels. So if it's constipation, we'll treat it with laxatives. If it's something other than constipation, then they still go NPO, but now they're going to get an NG tube because they need to go to surgery to remove this obstruction. But we want to decompress the bowel prior to surgery so it doesn't burst when they go in there to do it. So they usually get an NG tube for bowel decompression because when we suction air from the stomach, it actually will relieve some of the pressure that is coming up the bowel from behind the obstruction. So IV fluids will replace any fluid shifting, will hydrate us. Antibiotics will treat any bacteria shifting from the bowel. And surgery is going to be the ultimate treatment of anything other than constipation. The other kind of bowel obstruction that we have isn't really a physical obstruction, like a mechanical obstruction. It's the fact that you have an obstruction of movement because nothing is moving, no intestinal motility. And this has got separate causes and separate treatments. It's called a paralytic ileus or a paralytic obstruction, and it's not physically anything blocking the intestine. The intestines are not blocked by any constipation or any damage, any twisting, any scarring. It's just that the intestine isn't moving. So stuff gets added to it, but it doesn't go anywhere. This happens most often after abdominal surgery where the bowel becomes paralyzed just by maneuvering it and stunned muscle. Heavy narcotics can cause constipation because it decreases motility of the bowel. So heavy narcotics can cause a paralytic ileus. Sepsis can cause any kind of decreased perfusion to the bowel. Anyway, the difference is that you have no bowel sounds. None. Absent. Like none. You're listening in all 4 quadrants. Now, before you can say no bowel sounds, it's very similar. Saying no bowel sounds is as worrisome as saying no pulse. You have to listen for a full 2 minutes in all quadrants to say that you have no bowel sounds. And so you can tell this is probably not very common usually. So when you listen to bowel sounds, I'm sure this is taking you back to fundamentals. When you listen to bowel sounds, you should be hearing, blorp, blorp. And probably every 2 to 5 seconds, you should hear a blorp, normal bowel sounds. Hypoactive bowel sounds will be a blorp every maybe 5-10 seconds. So you hear bloop, and then 10 seconds go by before you hear another bloop. So you kind of listen for one and then you listen for another. Hyperactive vowel sounds, constant. So anyway, that was very dramatic interpretation of vowel sounds. Absent vowel sounds is you listen for 2 minutes and hear not a single blurb. You listen in the right upper quadrant, not a single blurb. Nothing in 2 minutes. So as soon as you hear a blurb, you don't have absent vowel sounds. Okay. As soon as you hear anything moving, you have hypoactive vowel sounds at least, and probably hopefully normal. You have to listen for at least 2 blurps to figure out whether you're absent, hypo, hyper, or normal. Absent means you've listened for an entire 2 minutes to that quadrant. And then you move to the next quadrant and listen for another 2 minutes. So in order to diagnose absent vowel sounds, you have listened for 8 minutes to the vowel. Do you know how many people I know are like, oh, absent vowel sounds? And if you go in there and listen for a minute, you hear one, and then you just don't hear another one for 30 seconds. So they're super hypoactive, but they're not absent, okay? Absent means you have listened to the vowels for 8 minutes and have heard nothing. That is paralytic ileus. And you can see that that is something that I know nobody listens to 8 minutes to a vowel. And so I see absent vowel sounds being documented when it's really hypoactive. Please don't be that nurse. Anyway, absent vowel sounds meaning nothing. No movement of that intestine at all. Massive abdominal distension because that intestine is not moving at all. You will not have any bowel movements, not because you are physically constipated, but because nothing is moving through the bowels. Because nothing is moving through the bowels, you can see that these bowels extend quite a bit, get very large, very distended, and can cause sepsis and hypotension. I have a terribly sad story about paralytic ileus. The treatment for it, again, NPO, if it's not moving, we can't put anything in the system. NG tube, decompression, get that air out of the bowel, stop it from distending so we don't end up with worsening Qs. And then there are medicines that will improve gut motility. You've probably given some of them before. Reglan is one of our biggest ones, metoclopramide. Relistor is a great one for getting rid of the opioid effects of or the GI effects of opioid. It basically blocks the opioid effect. It blocks the intestines from binding with opioids. Anyway, gut motility stimulators are the big treatment of choice. Decrease narcotic use if they're on it. Antibiotics if you need to prevent bacteria transferring across the membranes. IV fluids to keep things flowing. So my sad story about paralytic ileus is I had a patient, CRT, and you can forward through my story if you don't want the story, but was a CRT from the floor in the evening, and the nurses on the floor had been getting this patient up, walking him around. He had a nephrectomy, so he had abdominal surgery to remove one of his kidneys, and man, this boy was bloated. He was bloated to the point where he was short of breath. Big, huge, giant bowel, and so they called me because they said they kept calling the surgeon, and the surgeon didn't want to do anything. So massively, distended, short of breath because of the distension was pushing up on his lungs. And the doctor had been telling the nurses for the past 8 hours to get him up and walk him around. They said that he wasn't moving around enough. He needed to get up and walk around because, of course, ambulation and stuff will increase the motility of your intestines. But this patient couldn't walk anymore because he was so distended and he was short of breath. So the nurses called the CRT so that I could give him an order for an NG tube. Well, unfortunately, as a ICU charge, we only have limited orders that we can give out on a CRT. I said, I can't give you an order for an NG tube, but I can call the doc for you, and they said, good luck. So I get on the phone with the doctor, who I will remain nameless, but I hope he is not practicing any longer. Anyway, he goes, would you want an NG tube? And I said, I don't think that's really the point, sir. He's massively distended to the point where he can't even take a good breath. And he says, well, those nurses need to walk him. And I said, they have been walking him, sir. That's not helping. We listened to his bowel sounds. I don't hear anything. He's massively distended. Do you want the NG tube? And he said, no, I'm not going to give you an NG tube, but I will give you an order for Reglan, and I'll give you an order for an abdominal an abdominal chest x-ray. Don't call me again. So we got the chest x-ray and the Reglan, and I told him he should be getting better now. Well, unfortunately, when I found out, I went home that night and wasn't back for the next 3 days or so. Turns out the next day, the patient died. The Reglan did not work, was not effective, did not stimulate his gut, and he ended up becoming metabolically acidotic, septic, and got CRT'd again, apparently that next afternoon, and died, which is terribly, terribly sad. It was probably not treated early enough with the gut motility stimulators. So by the time we gave the gut motility stimulators, or by the time the nurse had gotten the chest x-ray or gotten the abdominal x-ray, the gut had already started leaking bacteria and fluid, and to the point where he became septic and ended up passing of massive sepsis later on that day. So, I mean, the nurses were trying everything. It was just basically delayed treatment of a paralytic ileus, and it was terribly sad, but just to the point where you can die of sepsis from bowel swelling due to the fact that it's so distended that it has leaked bacteria and fluid, and you become fluid, what's the word I'm looking for? Oh gosh, I probably need to go eat food. Fluid depleted, and you get bacteria, you get a peritonitis, you get sepsis. And that was terribly, terribly sad, all for the lack of not intervening sooner with this paralytic ileus. So again, just kind of teach your patient why you're doing the things that you're doing. Let's keep moving. We'll talk a little bit about lower GI bleed, which again, we've kind of covered when talking about these illnesses. If you've been through the gastric and the gastric esophageal, we talked about upper GI bleeds, which is from the stomach or the esophagus. Lower GI bleeds are anywhere in the intestine. And basically, if they're lower in the intestine, you don't usually vomit any kind of blood. You pass it through your stool. So you're looking for the stool to see if you can see blood. The longer it's been in the intestine, the darker it is. So melena is black tarry stool, and bright red stool is either in the colon or rectum area. Worsening cues will be losing so much blood that you have a low blood pressure, tachycardia, or anemia. Really intervening is really going to be the same as any kind of bleed. You want to give IV fluids for any kind of bleed, give blood products if necessary, but really you need to find the source of the bleed and stop the bleed. And if it's coming from the GI system, you want to go in, either do a CT scan, a colonoscopy, or they may need exploratory surgery to find and control the source of bleeding. A little bit about a colonoscopy. Again, I kind of showed it to you as a diagnostic tool. It is a diagnostic tool. Before the procedure, though, there's a little bit before. With an endoscopy, there's not much to prep for an endoscopy. They're putting the scope down into your esophagus, into your lungs. But with a colonoscopy, they can see better with a clear colon. Well, you can imagine a clear colon requires clear liquid diet and a lot of pooping to clear that colon out. So it's a clear liquid diet for at least the day before the test, nothing by mouth before, and they're usually doing a colon prep, which is a bowel prep, which is basically a big-time laxative, which is going to clean out the bowel, basically remove any stool from the bowel, and then you flush that out with clear liquids, and so they have a beautiful, pristine bowel to look at. If you don't finish the bowel prep and they don't have a clear liquid diet, when they go up with the scope, all they're looking at is poop, and they can't see the intestinal wall, and they get mad at you, and they send the patient back and snipe at you. So After you put a scope into the colon, we expect maybe a little small amount of blood in the stool, depending on whether they biopsied something. Again, there's tools on the end of the scope. They can biopsy worrisome things. They can cauterize bleeding. They can do any number of things as long as it's in the colon. So you might expect a small amount of blood in the stool. It should clear after 1 or 2 bowel movements, and it shouldn't be extensive bleeding. They do air. They'll puff air into the colon to dilate and to see better. So a lot of flatulence afterwards is normal. Maybe some mild bloating because of the air that they introduced during the colonoscopy. There is a risk when you're shoving something up through the colon that you could perforate it. So again, our biggest complication after procedure, our most common, is actual bowel perforation. High fevers, abdominal pain, guarding in all 4 quadrants, firm, rigid abdomen distension, meaning we probably have an infection in our abdominal space. If you poke a hole in the colon, anything leaking out of the colon will be into the abdominal space. Bleeding. Again, if you puncture the colon and have a bleeder and you're bleeding into the abdominal space, it may come out in the stool but it also may be bleeding into the abdominal space. If it's bleeding into the abdominal space, you'll have Turner-Cullen sign, flank bruising, low BP, increased heart rate. And I would say I should probably add in here increased blood in stools too. So let me go back. You can add this to the thing, increased blood in stool. Because you could bleed into both places. You could bleed into your abdominal space, or you could bleed into your colon and it will come out as blood. So we'll be kind of keeping an eye on our bowel sounds, our bowel movements, our abdominal pain in case of any of the complications. There really isn't too much care. The main complication, again, is a perforated colon. So we're going to be keeping an eye out for that. I think you can read the rest, and I do believe, we have to talk about abdominal surgery. Because for Crohn's, ulcerative colitis, obstructions, the treatment is abdominal surgery. So if they've had any kind of open or laparoscopic abdominal surgery, I wouldn't be surprised to see an NG tube to relieve any abdominal or intestinal distension. Again, if you're going in there and cutting intestine, you have sutures and you don't want those sutures to be distended, and an NG tube will keep air out of the stomach, but it'll also keep air out of the intestine as well. So NG tubes will relieve the distension in your abdomen or your intestines. IV fluid, more than most surgeries, because fluid electrolyte shifts in the intestines, especially while they're doing surgery on them, while they're distended for any reason. JP drains to drain the surgery. After surgery, you're at risk for a paralytic ileus, but usually hypoactive bowel sounds when they pick them up and they throw them they pick them up, drag them out, throw them on the surface, maneuver with them. They get a little stunned. The anesthesia slows them down. Hypoactive bowel sounds is expected, and so we just want to keep an eye on it. Fluid and electrolyte imbalance, again, after abdominal surgery, you do have some stunned intestine and slow-moving intestine, increased pressures in intestines. Sometimes when they're doing those surgeries, they puff air into the intestines. A lot of abdominal surgeries have a lot of fluid and electrolyte imbalance. Atelectasis, because anytime you're after surgery, you're at risk for atelectasis, especially under general anesthesia. We're not expecting paralytic ileus, which is completely absent bowel sounds with massive abdominal distension. Again, not good, because one, your gut is not functioning at all. And that distension could damage things that were going on during the procedure. Infection is not expected, bleeding is not expected, and atelectasis progressing to pneumonia is not expected. Monitor the wound site, the drains that you have in, the pain level, location. You're certainly watching for your bowel sounds, making sure they don't go away, making sure they start coming back. And most bowel surgeries will have prophylactic antibiotics because you're messing around with dirty intestines, basically. And there is that risk of bacteria as well as fluids crossing over into the peritoneal space. NPO until bowel sounds resume, and then slowly advance diet, get up, ambulate. I don't think I put, I did put early ambulation on this slide. Pain medication, but be careful with opioids. They're already at risk of a paralytic ileus due to bowel manipulation. We don't want to increase that risk with opioids. Get them up, get them moving. That increases gut motility. It's good for your coughing, deep breathing, good for atelectasis, good for preventing pneumonia. And we also don't want any bending, lifting, straining for 4 to 6 weeks because that increases the risk of suture problems. So I think that is about it. That ran a little long. I'm sorry about that. But now you know everything about intestines.